So this is a 20-year-old female who presents with a cardiac arrest after swimming. So I didn't get to talk to her about this incident, and I asked multiple people, but this is kind of the gist that I got. She works as a lifeguard. She actively swims in that area. Her friend, she was in the pool. Her friend dunked her head under the water. She got up, and as she was attempting to leave the pool, got a little bit dizzy and lightheaded, and then all of a sudden became unresponsive, and then fell back into the water. She was pulled out of the pool by an off-duty firefighter who then just started CPR, and then they attached an AED, which then delivered 3 shocks. When EMS arrived, she had a pulse. They intubated her in the field. They got a pan CT, which did not show any evidence of trauma, but it did show bilateral upper limb opacities, and she was admitted to the ICU. For her past medical history, she doesn't really have any significant past medical history. She does say that she was getting dizzy and lightheaded sometimes, more often when she stands up from from sitting to standing, but no real other past medical history. Doesn't really take any medications, maybe some Tylenol here and there. No significant surgical history. The family history is a little interesting. On her mother's side, there's a history of family members that have what they call vasovagal syncope. They never gotten a full cardiology evaluation, so no one's been diagnosed with anything, and there is no family history of sudden cardiac death. Social history: she denies smoking, alcohol, and drugs. She works as a lifeguard, and like as we mentioned, she's an active swimmer, presumably exerting herself often. So this physical exam was not my physical exam. It was performed by the trauma service and then the critical care service. The vitals she was afebrile, heart rates were in the 80s, blood pressure was 133 over 70s. She's saturating 100% on the vent. When she presented, she was intubated. I tried to find a neuro exam that kind of showed what she was doing, and so this is the critical care ICU's neuro exam when she's taking off a propofol. And then in that exam, they documented that she opens her eyes, has some purposeful movement, and had normal muscle and tone. For her rest of her exam, based on what I was reading from the chart, it was relatively insignificant. The lungs, they said it was clear to auscultation bilaterally, but there was bilateral opacities in the upper lung. And so this was her EKG on presentation. I'm going to show you a few EKGs as they changed a little bit.
This is a 20-year-old healthy woman who is a regular exerciser because she's a lifeguard and swims regularly, who has no past medical history, is not taking any medication, doesn't have any substance abuse problems, who, after maybe being dunked in the pool, has a syncopal episode, and she's taken out of the pool by her lifeguard EMS friends, who, when they attend her, she has no pulse. And actually, when they put an AED on her, the AED does deliver 3 shocks. So the AED at least determines that there may be a shockable rhythm. And she is resuscitated successfully, and then now she's here in the ICU on a ventilator, but seems to be waking up. So, Dr. Ortman, what's going through your mind? And she has this interesting family history of recurrent syncope in multiple family members on her mother's side, but they've been labeled as vasovagal syncope. No one has died from these episodes.
So when someone's been shocked by an AED, usually I assume that it was an appropriate shock. So you have to assume that she was shocked for ventricular arrhythmia. The sensitivity of the external defibrillators are pretty accurate. And so, you always want to see a strip for documentation purposes, but when you hear that story, I usually just assume that it was correct. So then you have a young lady who presumably had a cardiac arrest, sudden cardiac death, resuscitated, and in this demographic, you're not really worried about coronary disease. You're worried more about inherited channelopathies. And so what strikes you about this tracing, there's two things. One, she's very bradycardic. And if you notice, I'm not sure if it projects the arrows, but there's P waves, which are then taken over by QRS complexes. So there looks to be like a prevailing junctional rhythm. There's P waves at the start of the tracing that then get taken over without any change in heart rate. So this is a junctional rhythm at a rate, in the 40s. And then there's also QT prolongation. The QRS complexes themselves are very normal, but the QT is prolonged. Now, the QT is proportional to heart rate. As your heart rate slows down, the QT extends and vice versa. But not only is the QT prolonged, but there is some notching here. Now, the question is this notching here, is this notching from maybe a superimposed P wave, or is it notching of the T wave? She has other 12 leads where the T wave looked different than this morphologically. So really the only thing that strikes you here is the prolonged QT. Now, when you're thinking about sudden cardiac death, you're thinking, the 12 lead, despite what Dr. Aji says, the 12 lead is a very useful tool. It can show you a lot of things. It can tell you about, you can identify signs of Brugada syndrome, which are not present. There's no cove pattern. You can look for signs of ARVC, which would be T wave inversions through the precordial leads, an epsilon wave in V1, slurred S wave in the anterior leads not present. Obviously, we're looking at the QT interval. Long QT most often, short QT very, very uncommon. There's no signs of any structural heart disease to suggest hypertrophic cardiomyopathy. So really, you're left with sinus bradycardia, junctional bradycardia, prolonged QT, which I'm not sure. I think it might correct for heart rate, but then you have this notching. And with long QT syndrome, it's not just the absolute QT, which is abnormal. It's also the morphology of the QT, which the QT itself, the T wave, should look morphologically abnormal in most of these patients. The problem, as I'll talk about, is that the morphology and the absolute QT interval can change. So, you're most likely at presentation to see the abnormality. I mean, if someone's coming in after a cardiac arrest, that's when they should be, phenotypically most obvious. The problem with long QT, though, is that there's variable penetrance, and from day to day, even someone a genotypically positive patient may have a completely normal QT interval. So it's not abnormal all the time. And the same holds true for other things like like Brugada syndrome. These are dynamic changes which may show up and resolve from one moment to the next.
Let's look at some more EKG. She had to show the.
So
your point is going to be shown here on the subsequent ECGs.
yeah, so I have a few more just to show they like vary between a couple of hours apart to the next day.
And here you could see, there's junctional rhythm, and this is junctional with retrograde conduction, because if you notice that the P wave is very narrow, it's extremely narrow and it's inverted. So, the atrium is being activated retrograde through the interatrial septum, and then you're concurrently activating the left and the right atrium at the same time. So this thin, narrow retrograde P wave is an inverted P wave. So now she's just completely junctional, and her QT is still prolonged. Absolute QT interval here is greater than 600. It does correct for rate, but it's prolonged nevertheless.
This is just her going a little faster.
Yeah, and here, here the QT it's obviously shortened with the higher heart rate. She's in a sinus, looks like a sinus mechanism here. But in other leads, there's another 12 lead where you start to see this kind of funny notching pattern in her anterior precordial leads in the T wave, which makes you think of a certain diagnosis, long QT syndrome, specifically type 2.
I'm not sure if this again.
Funny looking T waves.
Yeah, I mean here the QT is clearly prolonged. I mean, it encompasses more than 50% of the R interval. The absolute QT is not huge, but at this rate, clearly I don't know what the corrected QT would be. I have to measure it, but it's long. I mean, this is 70%, 60% of the R interval, and there's this kind of notched appearance you can see here in V2 and V3. There's like a notching of the T wave that's more evident than in other tracings.
And again, just a point for early in the year, to measure the QT, get a 12 lead and look at the lead with the longest QT interval, and that's the QT interval.
Yeah, I'll go over that in my talk a little bit.
And V5 and V6 here, that looks the longest to me. V6 is more than 400 milliseconds at this heart rate. That looks like it's about 440 or 460, so that's pretty long.
So this is her labs on arrival. White count, hemoglobin were normal. Didn't really have any abnormalities in kidney function. Potassium was 3.9. Mag was a little bit low at 1.5. Calcium was 8.4. This ABG was on arrival. It corrected once she was on the vent. Toxicology was negative. High sensitivity trope detect 1 was 18. COVID was negative, and NT pro BNP was not checked. This is her chest X-ray on arrival. The bottom got cut out a little bit.
Yeah, I mean, it looks like she just quickly go through this because I think she did not have a lot of pulmonary problems, but it looks like she had aspiration as part of her resuscitation.
In the ICU, she was eventually extubated. She did well when she was weaned off of sedation. And so after she was extubated, she was mostly back to herself. She was alert and oriented ×3. They consulted EP.
This is within 24 hours, I believe, right?
Yeah.
Yeah. So she gets better pretty quickly.
Mm-hmm. So here's a few ECGs that occurred while she was awake. I think this one's pretty similar to the last one. They caught this on on telemetry.
And the initial consult, I believe, was because she was bradycardic and had junctional rhythms, and they were worried that was the cause of her presentation rather than ventricular arrhythmias. But Dr. Portman pointed out that the AED firing makes you worried that this is not the whole story.
Yeah, and the other thing that strikes you, though, interestingly about this, I mean, even when she's having multiple non-conducted P waves, number one, her sinus rate doesn't, it doesn't really accelerate very much. I mean, if you see non-conducted P waves, if the level of block, sorry, I'm not on. Okay, I thought I was on mute for a second. If the sinus rate accelerates, that's a sign that it's pathological AV block, regardless of clinical circumstance. If you see someone has a PAC and then they have multiple non-conducted P waves, but the P waves come faster and faster and faster, they're telling you that it's not vaguely mediated. Here, the sinus rate's pretty slow.
But they don't project really well, I think. But these are the P waves here.
Yeah, there's P waves at about a heart rate of 60, and then when she has her escape, sometimes this is particularly important. This is an important point when you're on service and you're loading a patient with a drug in particular, like a class 3 antiarrhythmic drug like Ticasin or Sotalol. You don't want to just look at the 12 lead for their QT. You want to look on telemetry, and if they have any pauses overnight, whether it's due to a a fully compensatory pause after a PVC or transient AV block while sleeping, you want to look at the QT after the pause, because in some cases, especially when you're subjecting someone to a drug like a class 3 antiarrhythmic, there's a significant QT prolongation that can occur after the pause. In this case, her QT really doesn't change all that much. It's prolonged, but there's no pause-dependent QT prolongation that you might see if you're putting someone on a drug like Sotalol or Ticasin. And if you see that, that's a real red flag. It could be arrhythmogenic. So even if their QT is normal at baseline at a sinus rate of 70, the concern would be that they're having longer QTs at sleep and they might be subjected to proarrhythmia. So post-pause QT prolongation.
This is just another another strip.
Pretty long.
Yeah.
Again, sinus rate doesn't really change all that much. It's kind of constant, and it makes you think it's like a vagal, I think like a vagal phenomenon. I mean, I don't think that she had any intrinsic AV nodal disease. I'll put it that way. She's not. She's got a narrow QRS, normal PR interval. You know, anyone can have AV block. It doesn't mean that there's a problem with the wiring. So there's nothing wrong with her wiring. I don't know why she was having these episodes, but they do appear to be, I would say, either vaguely mediated. I would say vaguely mediated. Maybe a little acceleration here, but it's hard to say. At the very end, you have to measure it.
This is her echocardiogram.
In the interest of time, we'll just summarize to say that it was unremarkable for structural abnormalities.
As Dr. Ginsburg said, the RB looked good. There was normal wall thickness, and there was no significant LBOT gradient. The normal EF. And so this is what we got a stat phone call for.
This is like, I think this is sort of after she's been in the hospital about 24 hours. I believe she's extubated here. Again, everybody was somewhat worried about her bradycardia. And Matt, this is, I know we have a long strip here, but that looks like torsades to you? Or going to be torsades? Oh, there we go.
Yeah, so if you look, I mean, so it starts out, she has a long QT, so that's number one. You have to have a long QT. And the second thing is she's having, looks like PVCs. It's hard to see. I mean, it looks like this is her, I don't have the pointer, but her sinus P waves, if you march them out, you can kind of see where there's PVCs are rising from just after the T wave of a very prolonged QT interval. And then there's a relative pause. Typically what you'll see with torsades is that you have PVCs with pauses in an escalating pattern. The PVC causes a pause. The pause causes more QT prolongation. You have another PVC arising from the the T wave, so-called EAD, early after depolarization. And then eventually you hit the sweet spot, and the PVC here initiates a polymorphic VT, which on the next strip is like classic for torsades. I mean, it's twisting around the points. I mean, yeah, this is definitely torsades, the constellation of QT prolongation. Pause dependence not really totally obvious on that strip that you just showed, but the whole picture is consistent with torsades. And so usually torsades terminates on its own. That's why usually people pass out, they don't die, because with the increase in heart rate, the QT shortens and it essentially burns itself out. And you could see on the last run there, the T wave kind of, the QT is shortened, but then the sequence repeats itself because bradycardia resumes, QT prolongation resumes, early after depolarizations resume, fully compensatory pauses resume, and then eventually you have torsades again. So usually it's syncope, not sudden death. In some instances, though, it can degenerate into VF and necessitate external defibrillation.
So this episode lasted 43 seconds. JL was walking around showing everyone the strips. She didn't lose consciousness, but she felt very nauseous. Felt really unwell. I think she might have vomited during this. But then it came back and she was back to relatively normal. So EP saw her. They recommend starting isoproterenol to keep the heart rate elevated. The recommendation said keep the heart rate 90s to 100. They recommended Lyme titers, which were negative, and then she was transferred to the CCU. This is just her ECG when she's on isoproterenol.
There's that very abnormal looking T wave that got
Yeah, I put this in my talk too. This is when you look at the 12 lead, you want to make a guess. You want to guess what the genotype is. First, you say, okay, I think they have long QT, and then if you want to get fancy, you could try to guess what their genotyping will show. And then there's notching there. This doesn't look like the broad T wave of long QT1. But who knows? The only way to really make that genetic diagnosis with genotyping.
So I didn't want to guess which lung QT it was because I asked 3 people and they all told me a different answer. And so I just said we'll need genetic testing to determine type.
So you got a 1, 2, and 3.
Yeah, I got 3 people that said 3 different answers. So her CCU course, she had a brief episode. A complete heart block lasted a few seconds, resolved. Had a cardiac MRI that didn't show any structural heart disease. And then she had implantation of a dual chamber ICD, and she started on Nadolol, 40 milligrams daily, and then is going to follow up with EP outpatient.
So just quickly before your talk, Matt, you want to talk a little bit about subcutaneous ICD versus an endovascular device in this particular young, physically active woman?
Yeah, I mean, well, for two reasons you'd want to pick a dual chamber ICD. For one, she did have those episodes of heart block, and although the sub-Q ICD can deliver external pacing for a short amount of time after a shock, it's not really meant for that, and it's painful. It doesn't have a pacing function. So, if she did have recurrent heart block, you wouldn't have the ability to pace, whereas with the transvenous device you do. The second thing is, if she were to go into a torsodogenic event, you have the ability to manage that with ATP, which is anti-tachycardia pacing, where the device will pace into the circuit and potentially terminate it without the need for a shock. You don't want to program these things super aggressively. You want to try to. The purpose of the ICD is to prevent sudden death. I mean, it really does not necessarily prevent syncope. But if you have the ability to pace, you can potentially intervene. And the other thing is, if she ever had a situation where she was really heating up for whatever reason, you could pace her. You can increase her heart rate with atrial pacing, and shorten her QT, and thereby avoid the need for intravenous drugs, temporary pacing. You can't do that with the subcutaneous ICD. The sub-Q ICD, the advantage is obviously that it's subcutaneous, and in a young person, that's always preferential. But it's also bigger, and the bottom line is, I think for her, there's no question that the transvenous ICD was the more appropriate choice.
And one other question, driving and lifeguard work, because she can't be a lifeguard anymore?
Yeah, I would say, I'll talk about that a little bit. That's the question is, what do you do in follow up? So my plan with her, I'm going to see her actually in a couple hours in clinic. My plan is, after she recuperates for a couple more weeks, I'm going to put her on a treadmill just to give her the confidence, exercise in a monitored setting, just to get back to a relatively normal lifestyle. I think swimming is problematic given the nature of her event. And technically speaking, long QT syndrome, even recreational swimming is contraindicated. Now, if she wanted to really swim and she had someone who's there with her monitoring her, I would be okay with it personally, because she does have an ICD. But she should absolutely never go swimming unsupervised, by no means. And in terms of lifeguarding, I think that just given the nature of her event, I think that's probably, when you're a lifeguard and you're rescued from drowning, you're probably no longer qualified to be a lifeguard. And she's not really, but the thing is, she's not really wedded to the idea of swimming. I talked to her about it a little for a while, actually, and she does run. She likes to jog, and I'm okay with that too. But what I told her too was, at least for a while, she should never go jogging by herself either. She should always jog with a partner, and not competitive jogging, just jogging. You want to have balance active lifestyle with safety. You don't want her at 20 to stop exercising, because there's a lot of benefits that she'll lose. Swimming probably out, exercise still in, but with restrictions. And I think the treadmill, I think, is a good way to get her confidence back. Also, to know that she's not going to get shocked by her ICD with activity, because that's another potential fear that patients may have.